So, on to the last lecture, ENT, which is a very common presentation actually, one of the commoner subjects that GPs will see compared to, say, MaxFax, for example, or plastics. And we're very lucky we have Mr. Ryan Chong with us. Mr. Ryan Chong is an ENT consultant and specialist sleep surgeon at the Royal National ENT and Eastman Dental Hospitals in UCLH. He is a subspecialist in snoring and obstructive sleep apnea. And if we finish a bit early, he can tell us if anything actually works for snoring. I'm sure he'll say it does. Ryan and I went to medical school together, and it's generally impressive to see how much he's achieved in such a short space of time. Ryan has always been a very high achiever and is actually a multi-award winning surgeon. So we're very lucky to have him here. Please welcome Mr. Ryan Chong.
Well, thank you, Khalid, for the very kind and generous introduction. It's a pleasure to share the next hour and a half or so with you. It's a very well organized course, so congratulations to Khalid and the rest of the team. I understand you've had ophthalmology and MaxFax already today. Having a good time so far? Yes. Excellent. So as Khalid introduced, my name is Ryan. I'm one of the consultant ENT surgeons at UCLH. It's part of the Royal National ENT Hospital, so it's an umbrella organization. We are one of the largest ENT hospitals in Europe at present. My area of subspecialty, as Khalid would tell you, it's in sleep apnea and snoring interventions. But we will go through the breadth of ENT in general. And if we have time, we will cover some bonus topics. And if we really have time and if we're doing really well, we can talk more about snoring and sleep apnea right at the end. So that's your motivation for paying attention. So just going through the list of subjects that we will be talking about. And from what I gather, ENT is quite a common general practice topic, right? I think almost a third of what you see in general practice is ENT related. So hopefully over the next hour or so, we can talk about certain cases, hopefully answer any questions that you might have, and go through this list of topics over here. So the first thing we'll be talking about is the ear, followed by the nose, and then the throat. So we'll go through a particular case in the first instance. So 24-year-old woman presents to your clinic with a swelling of the right ear. She feels well. She's had an ear piercing a few weeks ago. And then you see this. Any ideas, thoughts of how you would approach this case?
Antibiotics.
Very good. Any other thoughts?
Responses are to refer, antibiotics, yeah.
The piercing won't come out easily now, it is very edematous. So you have to wait for the swelling to subside before you can take that out.
Very edematous, okay.
I was going to ask if there's a picture of the like another aspect.
The posterior aspect of the ear.
Aspect of the pinna.
So no, the earring is embedded in this area, so you can't visually see it from the posterior part of the ear.
Removal of the earring.
Exactly. So I'm hearing removal of the earring, antibiotics,
Refer.
and refer. Excellent. Good. So which option would you go for? Anybody would leave the earring in? No one potential person? Anyone else? Yeah?
Leave the earring in or take it out?
Right. So, this is my thought. If you can remove the earring, you need to remove the earring because it's an insulting trigger for the infection. But if you're really struggling, then refer the patient on to an ENT on-call person. I would agree with most of you. Yes, it's B. Fluoroquinolone, so ciprofloxacin is a good option. It penetrates the cartilage well. Coamoxiclav is a broad spectrum cover for most pathogens for pinna cellulitis. Okay? So just to go through the anatomy of the pinna, as you would know, you have the helix on the outer rim. The pinna is generally divided into the cartilaginous framework and then the sort of soft tissue framework, of which the most interesting area is the lobule itself. So that's the ear lobule here. The reason why this is interesting is because you don't have any cartilage there. And that's a key distinguishing feature between this condition, which is pinna cellulitis, and the next one, which you'll be seeing in a second. So this is just to familiarize yourself with the anatomy of the pinna. You have the helix, which is the cartilaginous outer rim. You have the antihelix, which is the inner rim. And then you have the scaphoid fossa, which is the dip in between the two. The concha is the actual bowl-like structure, which is sitting close to the tragus and the external auditory canal. So, second case. This walks into your clinic. What are you thinking about? Thoughts? Cauliflower ear? Are you hearing anyone from that side? Refer?
This is swelling like this, probably extending from a otitis externa and then
There's some
involving
kind
all
of
over.
sparing that happens, isn't there?
Yes, exactly. Very good. Cellulitis? Any other thoughts of what this might be?
Malignant otitis externa.
Malignant otitis. Very interesting. Let's talk about that in a second.
Contact sensitivity due to age or
Very good. Very good. Anything else?
allergy reaction.
Allergic reaction. Fantastic. So these are all very good answers. This is an extensive case of what potentially may be a spreading of a sort of otitis externa. All the other answers are very relevant. So contact dermatitis, widespread cellulitis in this region. So there's a difference between pinna cellulitis and perichondritis. And the area that will help you distinguish between the two is the sparing of the actual lobule itself. Does that make sense? Yeah? So if you look at this picture over here, let me just go. So this one, if you look at the lobule, it's entirely erythematous and red. But if you look at this one here, over here, in a case where it's just perichondritis, you actually get a sparing of the lobule itself because the cartilaginous framework ends at the lobular region. Okay? So that's the main distinguishing feature that will help you determine whether something has taken hold of the actual cartilaginous framework or is involving mainly the soft tissue of the skin and the fat. Yeah? So the main differences, the causes for pinna perichondritis is the penetration of the cartilage itself. So that logically makes sense because if you have a penetrating foreign body, it's now hit the actual cartilage itself and it's no longer just on the superficial layer of the actual skin. Contributing factors for pinna cellulitis include otitis externa, like we talked about. Insect bites can be a common thing as well. Malignant otitis externa, we've sort of moved away from that terminology a little bit because the term malignant scares patients. So what we've actually shifted more towards is necrotizing otitis externa. Sounds less scary, apparently, to patients. But yeah, NOE is how we term it these days. And you're right in the sense that it is essentially osteomyelitis of the external auditory canal from extensive otitis externa. So when the bone of the temporal region of the external auditory canal gets infected, the bone itself, then you have what is termed as malignant otitis externa or necrotizing otitis externa. The risk factors for this condition include being immunocompromised, diabetes, being elderly, or if you had recurrent otitis externa episodes, not adequately treated with antibiotics, the patient keeps coming back to you, and then you're more concerned about this particular condition. Please.
Can all of these conditions not lead to each other? Is it not like Ludwig's angina, in which they're all spreadable everywhere?
Absolutely, yes. The key thing is for you in general practice to be able to triage and differentiate them before it evolves into those different conditions. Because if you leave it long enough, they can easily blend and bleed into one another. So for example, pinna cellulitis can easily turn into pinna perichondritis and vice versa. Otitis externa can easily evolve into malignant or necrotizing otitis externa. But the main challenge or skill that you guys have that we don't is that you see the undifferentiated patient more than we do, right? So the real sort of niche and skill set that you have and are able to deliver is to basically identify the occurrences with limited information. So the main take-home point is the lobule, is to be able to distinguish between perichondritis and cellulitis. The red flags, as we talked about, if there is an abscess that's evolved or developed, signs of necrosis, it's not a good thing. So if you see like the tissue of the ear when you do an otoscopy is starting to become very almost like grey-like, slough-like in nature, then you're a bit more concerned. You want to accelerate a referral to an ENT team as soon as you can. Common organisms, Pseudomonas aeruginosa for perichondritis. Pseudomonas, for some reason, loves cartilage. Staph aureus for the skin, for the cellulitis type conditions. So interestingly, I don't know if you're aware, but the fluoroquinones, of which the most popular is ciprofloxacin, has equivalent penetration orally and intravenous. So if you start someone on oral ciprofloxacin, the effectiveness is almost equivalent to giving them IV ciprofloxacin. So don't hesitate to start someone on oral ciprofloxacin if you feel that their cartilage is involved. Okay? So again, the things that may develop cranial nerve weakness, because the facial nerve runs very close within the anatomy of the temporal bone. So if a patient complains of earache, discharging ear, suddenly reports some facial drooping, some facial weakness, it's definitely something worth accelerating, because then you're thinking, why is the facial nerve now compromised? Is there something deeper going on, particularly osteomyelitis of the temporal bone, which we talked about? Okay, so persistent infection is the other thing worth referring. I think once you've initiated a course of antibiotics initially, and if the patient comes back to you with no significant improvement, then it's worthwhile triggering a referral at that point. Okay? And being immunocompromised is a risk factor as well.
So Ryan, just before the second case, a question of mine would be, if you go back to the case with penicellulitis, that picture, one of the red flags is loss of contours. Would you say that ear has lost its contours?
Yes.
Yeah. So that's not something we would give Fluclox to. It was something we sent to ENT straight away.
Yes,
Yeah.
I would agree. That's a very good point. So if you compare this to this, you can see the contours of the ear quite clearly. You can see that the sort of shape of the cartilage, the dip of the concha, the dip of the scaphoid fossa, but you lose that sort of contouring when things are more edematous, and then it just makes you a little bit more concerned whether there's deeper tissue that's involved and inflamed and infected. Please.
When it comes to pericarditis and the need for drainage, is that something anyone could attempt?
So question is about perichondritis and the need for drainage. Is that something that anyone could attempt? I mean GPs.
So I would say, if let's say there's an obvious fluctuant abscess or collection, there's no reason why you can't pass a needle to drain that. You won't make things worse, basically. So once an abscess has developed, there's very likely chance that there is already an infection of the deeper soft tissue. So by draining the abscess and then referring the patient on adequate antibiotics, you won't make it any worse. For example, you won't be seeding the cartilage any further because the deeper layers are already involved. But very good question.
What kind of needle would you suggest?
I would say any blue or white gauge needle with a syringe would be fine. All right. Good. So, second case. 30-year-old gentleman attends your GP clinic. History of pain in his left ear with low-grade fever. He feels generally well, apart from some mild pain and reduced hearing on the left. Observations are as such: 37.9 temperature, heart rate 94, blood pressure is within range. You look inside his ear with otoscopy and he's got a bulging tympanic membrane, and you diagnose acute otitis media, okay? You have a feel of the mastoid process. He says it's a little bit painful, but it looks like this. Thoughts?
Mastoiditis? Someone
Anybody?
said mastoiditis?
It doesn't seem to be an obvious boggy swelling.
Doesn't seem to be obvious boggy swelling.
What is it, the real?
But it's tender.
Exactly the same.
Yeah, it looks away from the neck. I don't know.
It does, yeah.
Looks away from the neck.
Yeah, to the
Yeah. Let's assume the other side looks exactly like this.
Symmetrical. Yeah.
I wouldn't be worried about it.
Yeah. Anybody?
So some said mastoiditis, some said wouldn't be worried about it. Hands up for mastoiditis. That's a handful. And the rest, no mastoiditis, send them home.
So this is a tricky one, isn't it? Because it's always playing in your mind that if the patient says, hey, the back of my ear is painful, and you look inside the ear, it's bulging, you'd be like, is this mastoiditis? Is it not? Do I send him to ENT? What do I do? So it's a tricky one. However, there are certain key features that indicate whether somebody has mastoiditis or not, and we'll go through that. particularly anatomical features. But I would say that by and large, this particular diagram is within normal range. He's got a bit of a weird ear in the sense that it's a bit pushed out, but that's just his ear. So the main things, so what would you do in this case, in the first instance? Anyone for A? A, yeah?
Was he febrile? Sorry, I missed that.
Sorry?
Was he febrile when he came in?
37.9.
Yeah.
Hands up for A. B.
Good. B?
C.
C?
So it's a complete split.
Yeah.
1/3 each.
Which is interesting because apparently A and C are reasonable options, okay? Both A and C are reasonable options. At this point in time, I wouldn't be overtly concerned about mastoiditis just yet. So just to give you a bit of an indication of what the mastoid process is, it's a part of the temporal bone, okay? And essentially, it's in a patient with mastoiditis, you get a tracking of infection, usually from the middle chamber of the ear, the middle part of the ear, and it tracks subperiosteally into that region. And that's why when the bone gets infected, it raises an abscess in the subperiosteal region, causing the boggy swelling, okay? You look inside the eardrum, it looks a bit red, and it shows signs of acute otitis media. And it can be gradual because if there is a buildup of infective contents within the middle chamber of the ear that has perforated and drained, that's actually not a bad thing. So the patient may complain of increasing pain, and this is the temporal timeline, increasing pain, and then suddenly they hear a pop or a sudden sharp pain, and then they get a relief, essentially. So they've essentially autogrommeted themselves, basically. It's like essentially what we would do in an emergency setting is basically perform a puncture of the eardrum to allow the fluid to drain out. Where it becomes concerning is that if that doesn't happen, right? If that process doesn't happen and the eardrum remains intact and just stretches, then the infective contents of the fluid of the middle chamber of the ear has to go somewhere, right? And then it tracks back into the temporal bone and then raises in the subperiosteal region. There are a few complicating factors with regards to acute otitis media that you need to look out for because of the proximity, again, to the facial nerve. So that's something to be aware of, that the facial nerve can be at risk of paralysis and damage if it's not adequately treated. So always, if a patient comes to you with otalgia, concerns of otitis media, always perform a cranial nerve examination you can, particularly focusing on the 7th cranial nerve, okay? Again, these are the features that you would see on otoscopy. The area behind is basically, there's a sharp angle called the auriculomastoid sulcus, basically, that becomes obliterated in the case of mastoiditis. So the sulcus that you saw in the first diagram becomes obliterated, and that is the boggy swelling that was referred to in your course guides, as you can see. There's a raised area where this particular sulcus gets obliterated, and frequently the pinna gets pushed forward anteriorly as opposed to laterally from what you saw in the original diagram, which is basically just a strange ear. And looks like this, okay? And when you press down on this area, it doesn't just look raised, but sometimes you can actually feel a fluctuance. So if you feel a fluctuance behind the pinna in the auriculomastoid region, that's almost certainly mastoiditis if there is also associated signs and symptoms of acute otitis media.
So
Okay?
the angle you're talking about is just the
Here.
behind the ear.
This area here. So usually there's a deeper crease, right? But you can see that this crease is blunted. Yeah?
Can you get mastoiditis without the AOM?
Very good question.
Question is, can you get mastoiditis without AOM? I'm just repeating the questions for
that's
the camera.
that's a very good question. I think it's very rare to have that. I think you would need some other infective source within the temporal bone. I would say that the probability of that happening is probably 2% chance. The majority of cases would have some originating source of infection from the middle ear itself, which will result in AOM symptoms.
Interesting that we did discuss this before, and actually, so if you're looking at the eardrum and you can't identify an acute otitis media, but you've got this kind of weird looking kind of swelling at the back of the ear, and you think, well, there's no otitis media, so can this really be mastoiditis? Well, the middle ear is not just the tympanic membrane, and what Ryan and I were discussing is that the infection could have reached the mastoid air cells before it reaches the tympanic membrane. So it hasn't got to the tympanic membrane yet. You can't see the otitis media, but it's gone in another direction towards the mastoid. So you might not actually detect the acute otitis media, but if you're suspecting an acutely unwell patient with a boggy swelling, that's mastoiditis, despite the fact that there's no otitis media. Would you agree?
Yeah, absolutely. So I would think that if you see features of mastoiditis like this, even in the absence of acute otitis media, obvious acute otitis media signs, I would still have a low threshold for referring these patients on. Okay? And urgency of referral?
Same day, straight away.
Yes, absolutely. And why is that? Very good.
Intracranial spread, that was the
Intracranial
answer.
spread, meningitis, intracranial spread. These patients can be quite sick. And just for your own interest, what we would generally do is to take the patient to theatre, make an incision, post-auricular incision, down onto the actual subperiosteal layer, release the actual pus itself, do what is known as a cortical mastoidectomy with a bone drill to access the middle chamber of the ear, and frequently we'll do a grommet as well. So puncture the tympanic membrane so that both sides are drained, just so that you know what happens to these patients. IV antibiotics.
How commonly do you see mastoiditis?
To be honest, it's becoming less and less common because you guys are doing such a good job in treating AOM.
Given that spots, it's one of the first.
Correct. Yes.
If it's not fluctuant, if it's not boggy, but there is a little bit of tenderness.
Yes. So if there's a little bit of tenderness without any erythematous sort of swelling, then I wouldn't be particularly concerned at that point.
Okay, so tenderness on its own is enough.
Yes.
It has to have redness and swelling.
Correct.
I mean, Ryan and I were discussing that there's a lot of things that make patients feel a little bit tender behind the ear,
Yes,
you know,
yes.
and so, you know, you're kind of feeling around, even if you put pressure enough, you know, anything will be tender, you know, so if you're examining and you say, oh yeah, no, that is a bit tender, doctor, but, you know, in the absence of other things, especially if they're well, and there's no acute otitis media, this is not going to be mastoiditis.
Agreed. Also, you have a retroauricular lymph node. So there's actually a tiny little node that sits just behind the pinna, right? Annoyingly, that feels sometimes like a fluctuant swelling, but it's actually a lymph node. And also annoyingly, this node can sometimes swell up. So with an ear infection, let's say with otitis externa, the retroauricular nodes can actually swell up. So when you feel it, one way of distinguishing what's an actual node and what is a genuine subperiosteal swelling is if you feel a little ball-like structure that's mobile, that's not mastoiditis. That's just the retroauricular lymph node. So that's a top tip for you. But again, it comes with time. You know, if you feel enough ears, you will be able to tell what is genuinely the mastoid process, what is the retroauricular lymph node. Make sense?
So do you work at night?
Sorry?
Do you work at night? Or
Do I work at night? I do. Yes. Yes. So yes, I do work. I've just come off a week of nights actually. So the answer is yes, I do nights. But thankfully, I have a lot of very capable registrars to take calls.
No, the reason.
Sorry. Yes. No. Yes. Of course. So. Absolutely. So if it's a genuine mastoid abscess, we won't let the sun set. We would operate on them on the same day. So yes, absolutely yes. Good. So we've already talked about this, but just to recap, I'm just going to keep repeating myself until you remember all the information, okay? So mastoiditis, raised swelling behind the ear, auriculomastoid sulcus is obliterated or lost. It's tender. If it's just mildly tender, it probably won't represent an actual true mastoiditis case. It's frequently associated with acute otitis media, so keep an eye out for that as well. Because like I said, it's incredibly rare. I've only seen it like once or twice where a patient has come in, you know, over a course of 16 years where they don't have any symptoms of acute otitis media. And that's because of what's happened in the mastoid air cells have become seeded with infection and they developed, you know, a subparietal osteal abscess through that route. But it's very rare. Okay, your favorite topic. No, not really. Sudden onset deafness. So, again, 34-year-old in their 30s, Khalid, these patients. attends your evening surgery, wakes up in the morning complaining of loss of hearing in the right ear. He feels well, complains of some mild tinnitus. It's the first time it's happened, okay? Observations are generally stable. The Weber's localizes to the left ear. The Rinne's test, the left ear is air conduction more than bone conduction. The right ear is abnormal. What's happened?
So can we go back?
Yeah. Here you go. So Weber's lateralizes to the left. Rinne's, the left is normal.
Is this a good time for this?
We've got a slide for that actually.
We'll go slide for this.
Okay, before we answer this question, right? Who is familiar with the Weber's and Rinne's test? Who's comfortable? Good. Very good, very good. So in order to adequately answer this question, that's the key piece of information, which we will demonstrate to you. I wonder if it's the right time now. So who's for A? Conductive deafness in the right ear. No. B? Left ear. C? D? No. Excellent. So before we dive into the Weber's and the Rinne's test, just to have a bit of an idea, in order for you to understand sensory neural deafness, there are a couple of potential causes for this, okay? So trauma, meningitis, previous ear surgery can cause sensory neural deafness as well. Any more central causes, so trauma, strokes, autoimmune condition can affect this area as well. And just to give you a bit of a rundown so that it's clear in your mind, so that you have this piece of information, is that I'm sure you already know, but the way that sound travels from the external environment, right? So the vibrations in my voice box is hitting your tympanic membranes. It's vibrating your tympanic membrane. It's cascaded through the ossicles, okay? The ossicles are then connected to the cochlea, and that is where sound, vibratory sound, is then converted into sensory neural inputs, okay? For sensory neural deafness, the area that's affected begins at the cochlea. So anything before that is conductive deafness. So anything from the pinna to the external auditory canal, to the tympanic membrane, to the ossicles, if any of these areas are affected, that will result in conductive deafness. But anything from the cochlea onwards to the cochlear nerve and into the actual auditory cortex is sensory neural. And that's where this makes more sense. So anything that impacts the cochlea because of hypoxic injury, because of central nervous system insults, it results in sensory neural deafness, okay? Right, so things to look out for on examination. You have a look with otoscopy. Again, check the facial nerve. You can do your balance testing, bedside hearing test, which we will talk about in a second. And ideally, it's time sensitive, right? So sensory neural deafness, the key thing to remember is you need to, not necessarily on the same day, but soon, within days rather than weeks, because there is a time window in which we can restore, potentially halt the progression of this condition. All right, let's talk about this now. So we'll demonstrate the actual Weber's and Rinne's test to you, so just so that you're refreshed, okay? Have a seat. Right. So the general tip that I would give, who does Rinne's first when you do a... Rinne's first? Rinne's first? Who does Weber's first? Okay. Excellent. And then the remaining people don't really do this. Okay. Anyways, so top tip, right? I would recommend strongly to do the Weber's first, right? The reason being is because the finding of the Weber's is then narrowed down with the Rinne's. Okay? So I'll demonstrate the actual examination and then I'll explain what it means. Okay. So what I would generally tend to do is to place it on the vertex. Okay.
Ryan, could
Yeah.
you do it from the other side?
Yeah.
Yes, because of the camera.
This side. Okay. So again, I would strike it on my knee or on the elbow or somewhere safe. And then place it on the vertex of the patient, or the forehead, okay? And then I will then ask the patient if it's louder in one ear or the other, or is it equal in both ears, okay? Okay, do you hear it louder in the right or left ear, or is it similar?
Similar.
Fantastic. And if he reports that it's louder in one ear, yeah, it means that it's potentially laterite, correct, yes. So the actual findings of the Weber's is that it lateralizes towards what? Side of the bad ear. What kind of bad ear? No.
Conductive.
Yes.
Conductive bad ear.
Yes. Yes. So this is the key piece of information that you need to remember. It lateralizes towards the conductive bad ear. Okay? You ready for the next piece of information? It lateralizes away from... Exactly. Right? So it lateralizes towards the bad conductive ear, but it lateralizes away from the sensory neural deaf ear. Does that make sense? And the reason for this is this. In a sensory neural deaf ear, your hearing is gone anyways, right? So the ear, the cochlea is damaged, the nerve is gone. So any auditory input, whether it's conductive or sensory neural, that bad ear is not able to pick that up, including the vibration from the tuning fork. So the only ear that's going to be hearing signal is the other ear. That's why it's lateralizing away from the bad sensory neural ear, because that ear is dead. Why is it lateralizing towards the bad conductive ear? Anyone know?
Because there's no stimulus from the air, right? So all the stimulus is from the bone. So it's rather than the other good ear, which has got stimulus from air and bone. So if it's all from the bone, it's going to lateralize to the conductive deafness ear, isn't it?
Exactly. Clear? Yeah? So now you have that set of information in your mind. You have, okay, now it's lateralizing towards a particular ear. And in this particular case, right, it was lateralizing away from the right ear, wasn't it? So in that situation, you've got two potential scenarios. One is sensory neural deafness in the right ear, or conductive deafness in the left ear. And that's where Rhenes comes in, right? The way Rhenes is done is you basically place it at the back of the mastoid bone, right, and ask them, tell me when that stops.
Stop.
Can you still hear it? Okay. So that's Rhenes positive, right? So you strike it, you place it in the mastoid process, he hears it, you ask the patient to let you know when the sound has stopped, and then you shift the actual tuning fork in perpendicular direction towards the ear canal and ask if they can still hear it. And if they answer...
You went to the side where the wave
Correct, first, but you do it both sides, just to check whether they have any conductive deafness in either ear, okay? But the fact that if you do the Rhenes and it's normal, it means that it's sensory neural in the other ear. Does that make sense? Because there's no conductive deafness in the Rhenes positive ear.
Plus, it's also useful from the history if they say that they can't hear from the right ear, and then you do Weber's, and then it localizes to the right ear, then it's most likely going to be conductive deafness. Like they've got wax and they've got a bit of water in their ear when they showered, and then they can't hear in the right side anymore. And so from the history, you'll know which one is the bad ear. Then Weber's will tell you whether it's really the bad ear.
Yes, absolutely.
Both have sensory neural. That's
So
bad
both,
luck.
yeah, so if both have sensory neural, the Weber's will lateralize to the better ear. Yeah? Because that's the ear that's able to pick up the signal. Yes.
So sorry, with this patient,
Yes.
the one you're describing, if you now went on the right ear, would he hear anything?
No, it's
He
gone.
wouldn't hear anything.
Yeah. Because it's dead.
Is it?
Yeah? So Weber's first, then Rhenes. That's the flow of
So
things.
the question was, sorry, you say
That he started off doing the Rhenes on the side that the wave was lateralized to. So now if he then switched to the so-called bad ear, would he hear?
Yeah, so
on the mastoid or
on the
ear?
sensory neural bad ear, you
gone.
wouldn't hear either
Yeah.
at the mastoid or at...
Or
the,
Yeah.
But there is a incomplete sensory neural
Yes,
hearing
yes.
loss. Yeah.
In those types of situations, it really depends on how much contribution is from the sensory or how much contribution of the hearing impairment is from the conductive elements. But usually it's quite clear, usually quite reliable. Any questions about what we've just done?
Why do we need to do Cauda first?
Because it's just more logical. It's just more logical.
The question was why Weber's first, I think.
Yeah.
More logical.
It's just in terms of your train of thought, it sort of flows better in your mind, basically. Because if you do Rinne's first, then Weber's, then you're like trying to work backwards almost. Does that make sense?
So that one, the running on the left was normal.
Yes.
Air conduction was better than the bone conduction.
Yes.
And then it was localizing
To that same ear.
to the same ear. So that is, I'm confused.
It's recorded, don't worry. We've
Don't
got it. I think that's the benefit of the recording.
Okay. So what? So this is the key set of information. I'm going to keep repeating myself. So Weber's, it lateralizes towards the bad conductive ear, conductive deafness, towards the conductive deafness, and away from sensory neural deafness. That's the main non-intuitive piece of information that you just need to memorize.
I think like nystagmus, like doing like the HINTS exam and these sorts of things. Thank you, Haro. Like doing the HINTS exam and acute vestibular syndrome. You often have to try and think for a second. It's a nystagmus to the right or nystagmus to the left, and then head impulse to the left or head impulse. Similar with Rinne's and Weber's, you've got to take some time over it, I think, especially because you're not doing it day in, day out, or do it on special cases, right? So, and the other thing is that these are pretty cheap as well, and they're good bedside table.
512.
512.
512 hertz. Yeah. Please.
So in a normal person, this should not lateralize to anything.
Yes, it will. Yes, exactly. So equivalent. It means that it doesn't lateralize.
Yeah.
Yes.
Yeah, so that was Weber's normally doesn't lateralize.
Correct. And the Rinne's positive is the normal, meaning that you go from the mastoid, and then when you shift towards the external auditory canal, they can still hear it. That's Rinne's positive, which is normal.
So your patient had right sensory.
Correct.
Yeah.
Yeah.
And it's a pretty high value test because it's time sensitive. And you'll be able to, in your clinic, identify whether this is sensory neural or conductive. Because if it's sensory neural, you need to put in an urgent ENT referral for one of us to review, to treat them sooner rather than later. Very important thing that Khalid mentioned is that make sure there's nothing in the ear canal, like wax, that's causing the obstruction, right? So you need to, not just with the, I don't want you for the next week to just do Weber's and Rinne's on your hearing patients. Make sure you look inside the... Correct. Wax and foreign body are way more common than sensory neural hearing loss. Yeah? Good. So management for GP practice is prednisolone, right? 60 milligrams once a day for 7 days. And then you can taper that over the course of the next 5 days. It's guidelines by ENT UK. So yeah, although there is not strong systematic review evidence, I would still suggest that you have very little to lose. Obviously, counsel them with the side effects of steroids. But if you had a patient that you've done the Weber's and Rinne's and you're concerned about sensory neural hearing loss, it's time sensitive. So they have a particular window where you can administer treatment for them to recover. And then you yes, please.
If you're outside of that time window, what do you do?
It's a bit more tricky.
Question is, outside of the time window, what do you do?
Yes, that's a very good question. So this is my personal opinion. Let's say if I was week 7 and I had sensory neural deafness, I would still want to take the steroids, personally. But that's my personal opinion, right? Because even if the evidence doesn't necessarily support it, like I want the best shot to improve. But you do have about 6 weeks to get them to an ENT clinic.
How does the steroid work on the sensory neural deafness?
Very good point. So what
was the question?
How the steroids work to improve sensory neural. So, correct. So one of the theories for sensory neural deafness is that there is a hypoxic burden and inflammatory process that's impacting the sensory neural pathways. And inflammation plays a huge role in that. So they think that you have some kind of either idiopathic or external trigger to inflame the cochlea, inflame the nerve to a point where it's shocked. So the steroids help by reducing that inflammatory process to halt further progression and damage to the cochlea.
And the inflammation happens because of hypoxia and what did you say?
So you can have viral infections, just idiopathic, it just happens from an inflammatory response in the body. You can have autoimmune conditions, insults to the actual sensory neural pathway itself from surgery. But the most common, probably viral in etiology, that's just caused an inflammation of the cochlear organ. Okay, good. So when you send it to one of us, I usually advise my team members to say, look, we need to counsel the patients to consider intratympanic steroid injection. So we'll talk about that just for interest so that you're aware of what happens after you refer the patient on. There are certain units in the UK that have hyperbaric oxygen chambers. It is also an option. I think the one in London is in Whipps Cross, I believe. They have a hyperbaric oxygen chamber there. But there are some other hyperbaric oxygen chambers in the east of England where they're near the coastline for the Navy and the Marines. But MRI is one of those investigations that we tend to request if they have unilateral sensory neural hearing reduction. Anyone know why?
Acoustic constant.
How could it hear you? So
Acoustic neuroma. So that's a benign nerve sheath tumor that affects maybe 1% of patients with unilateral tinnitus and sensory neural hearing reduction. But it's worthwhile picking those patients up because then we can keep an eye on them because it can be progressive. Not always. Sometimes you can just monitor them with serial imaging, but it's worth getting a redo anyways. That's part of our practice. So just so that you're aware of what we actually do with these patients when they come and see us in clinic, intratympanic steroid injections, we numb the actual ear. This is purely for interest. We numb the ear itself. We use dexamethasone as one of the steroids of choice, about 10 milligrams per mil. All right. So we place sort of a long needle that we have in clinic that's specialized for ear canal injections. We then inject about 0.3 to 0.5 mils of steroid into the actual middle chamber. So we puncture the actual tympanic membrane and then we squeeze the steroids into the middle chamber of the ear. It can be painful. It can be painful, and sometimes patients complain of vertigo because we're just squeezing loads of steroids into the middle chamber of the ear. And then we generally recommend at least once a week, if possible, for a course of about 3 weeks or so. Okay? Again, just for interest, hyperbaric oxygen. So if we talked about the hypoxic injury and inflammation, what the chambers tend to do is to try to minimize this process by flushing oxygen into the cochlea and into the nerves of hearing. Okay? Pressures between 2 to 2.5 atmospheric sort of absolute pressures that's used within these chambers. Patients spend about an hour to 90 minutes in these chambers themselves, about 5 to 7 times per week. And then they go through a number of sessions. So this has some evidence to support potentially. This is what it looks like. You just sit there for about 60 to 90 minutes, just relaxing in one of these chambers. It's generally used for scuba divers, right? You scuba dive and then you have lots of toxicity of nitrogen. This sort of flushes it out, but it can be used for sensory neural hearing reduction as well. Like I said, the closest one is Whipps Cross. So, just to take home, right? They do not need to be completely deaf in the particular ear. If you do the Rennies and Webers, if it correlates, then be suspicious and then just refer them on in a timely way. Okay? Ear trauma. So, this patient, 3-4-year-old child? 4-year-old child comes into your clinic. What are you thinking about? Any thoughts?
Risk of perichondritis.
Risk of perichondritis?
NAI, perichondritis. These are the differentials.
Yes, it's a child. Yes, it's a child.
It's a child.
Anyone worried about anything else?
Juvenile spring eruption.
On the here? Yeah.
That's a shadow. Shadow on the tragus. Oh yeah, it's a sinus. That's a birth.
Yeah, that's a congenital anomaly. Not concerning whatsoever. Anything in the history you want to know?
Mechanism of this, what was, how it happened?
Fell off his dad when he was riding his back onto the floor.
True story.
True story.
Okay. What about this? Yeah? So I'm hearing cauliflower ear a lot. Let's talk about that in a second. So what is cauliflower ear?
It's formed here due to cartilaginous
If you leave that,
damage.
that will lead to a cauliflower.
Correct. So this is not cauliflower ear, but it may turn into a cauliflower ear if you don't do anything about it. Okay, so what is this? Yes. Pinna hematoma?
Yes.
That's coming later. Nope. Boop, boop. So yes, pinna hematoma. And it's different to this. Why? It's because of that hematoma, that it's actually present in the front of the pinna itself. Okay? And why does this happen? So there's a perichondrial layer, right? There's a sheath, like a fibrous sheath, that lays above the cartilage itself. And when it bleeds into that sheath, it stretches out and turns into a hematoma. The first case that you saw is actually just some soft tissue injury to the actual external pinna itself. No NAI. Parents were very responsible. They took them to A&E straight away. They texted their ENT consultant friend on the same day with photos to check. Yes, so completely fine. No concerns whatsoever. Please don't report them. This one, however, how would you manage this? Let's say we've established that it's a pinna hematoma.
When I had one of those in A&E, I put a needle in it and I drain off all the blood.
So stick a needle in and drain the
Very
blood.
good.
And it
Yeah.
worked.
Very good. Very good. So the interesting question is this. How long did it work for?
I don't know, I sent them.
So she doesn't know, she sent them home.
No, it's true though. So I'll tell you why I asked that question. It's because if you think about it, the perichondrial layer is stretched with blood, right? It's not a bad idea to aspirate it. That's sometimes what we do as well. So you can aspirate the hematoma as well. But there's a very high chance of recurrence because the blood can then just fill that space that has already been disrupted. Because now you have almost like a third space within the ear that's filled with blood and sort of fluids, right? So it can reaccumulate again. So aspiration is absolutely a reasonable approach. But then you need to refer them to ENT. And I'll tell you why. It's because they need some form of compression therapy to reduce the chance of recurrence. Okay? And how we do that, it varies from ENT clinic to ENT clinic. Sometimes we aspirate, like what you did. Sometimes we make an incision, like what you've done, to flay it, to drain out the actual hematoma itself. Sometimes it can be challenging if the blood has already clotted. So if the blood has already clotted, it can be difficult to aspirate. Even if you make an incision, it's all congealed blood. But the important management step with these conditions is that they need some form of compression treatment to minimize the recurrence. And we do that two ways. One is we have a lot of compression bandages in ENT for ear surgeries, right? So we can make an incision or drain it, and then we put gauzes anterior and posterior to the actual, so we sandwich the actual pinna, and then we wrap your head like a turban in a way. And then we, keep it on as long as possible. Option number one, that's one thing we can, so basically it's a compression bandage, we wrap it around the head to make sure that the ear remains compressed. Option number two is that we can use a dental gauze, so the dental gauze that you use for biting down with dentists. We use 2 of those, sometimes 3 if the ear is very big, and then we suture the gauze anterior and posteriorly to sandwich the actual pinna itself, right? And then we follow them up in clinic again, assess to see if there's any recurrence. If it's nice and flat, we just cut the sutures and take the actual dental gauze out.
How long do you need to follow up for?
Every week,
For how long?
until it resolves.
So the follow-up is every week until it resolves. Question about timeline. So someone comes to you, typically people present to GPs whenever they want. So like 2 days ago, I did this to my ear. This guy.
Yeah.
What are we going to do? Is it congealed blood, we can't do anything, or it still needs to be drained, need to send to ENT in the same day?
Yeah, I wouldn't necessarily say that you need to send it on the same day unless you have concerns of infection. So if this has become infected, you're concerned about a pinna abscess, that's a different story. But if it's just a pinna hematoma, I would say in the next few days, get them into an ENT hot clinic, an urgent care clinic. They'll be able to manage it there. The main risk of this is twofold. One is the risk of infection, because congealed hematoma can quickly turn into an abscess. Number two is the risk of the cauliflower ear, which is basically what happens is that if the cartilage is damaged or insulted, it basically goes into this inflammatory process and turns into distorted ears in the peanut region.
Worthwhile if we're doing a hot clinic referral for this prophylactically giving antibiotics or not?
Yeah, why not?
So prophylactic antibiotics is reasonable if it's a hot clinic, but it's also reasonable to refer to ENT same day.
Yes.
Yeah.
Yes, absolutely. You'll find very little resistance if you say, look, it's got peanut hematoma. They'll be like, yes, please come over. Yeah, Augmentin is fine. Kind of a bonus topic. It's so ear trauma. So this patient comes in to see you in clinic, okay? And then you look inside with otoscopy. What does this look like? Yeah? Perforation, agreed. So, a perforation can sometimes be not as obvious as this. It can sometimes be quite subtle, right? So it can be a challenge to sometimes determine what is a retraction pocket, what is a perforation, is it just retracted or what's going on? So one tip that I tell my team members to be able to identify what is an actual perforation and what is potentially just a very deep retraction is if you can see two levels clearly. And if those two levels, you can actually identify the actual circumferential periphery of it. Does that make sense? Because sometimes you can have retraction that is slanted and it looks like a perforation, but actually you can't see the clear rim because it is not actually a perforation, it's just a very deep retraction. Does that make sense? So if you can see two levels and the full circumferential ring clearly, it's very likely a perforation. Okay, how would you manage this?
Keep dry. Keep dry and review in 6 weeks.
Keep dry, review in 6 weeks. Thanks.
We can do tympanoplasty if it continues.
Yes.
Tympanoplasty.
After 6 weeks or...
So we can do tympanoplasty.
Not me, but
Yes. So,
Question is what you would do.
yeah, exactly. No, very good point. Yes, you can. That's a very good answer. But down the line, what is the probability of this healing on its own? Pretty good. Yes.
How many percent?
But 80% chance. Okay. But let's say it's a bigger perforation. It covers about 50% of the ear now. Unlikely. So if the perforation approaches half of the eardrum, it's very unlikely that it will heal on its own. So absolutely right in the corner when you said, water precautions, advise them, protect your ears, please don't go swimming, please don't put your head in, please protect your ears when you shower. Because why? The external ear is equipped to deal with all the nastiness in the tap water, but the middle ear is made of mucosal lining. It doesn't like the external environment, right? So the eardrum has two functions. What are the two functions of the eardrum, tympanic membrane?
Protection and noise.
Right, exactly. So acts as a conductive drum for the ear, for the ossicles, and it's a shield for the middle ear. But you lose the second function when there's a perforation. So you just need to make sure they're not submerging themselves. You can monitor them, so there's a good chance that if it's a small perforation that it will heal over time. But if it's more than 50%, refer them on to ENT because then we need to fix it with a tympanoplasty.
And that's a routine. That's a routine referral.
Yes.
Yeah.
Yes.
How long are you going to wait for it to heal? How long does it take?
Very good question. I would say give them about 3 months or so with a small perforation. And if it's still persisting, then time to refer on.
Yeah. Question was how long to wait for it to heal, and the answer was 3 months.
Yes. And yes, please, you have a question.
Sometimes when you see the tympanic membrane perforated, I always wonder, is there something behind it? Some pathology that has caused it to drop? What sort of thing goes through your mind? What sort of pathology?
That's a very good question. So, by far
Could
the
you
most...
repeat the question?
Yes, of course. The question is, what kind of pathology am I thinking about when I see a perforated eardrum? Okay? Behind the actual eardrum itself. So, that's a very good question. The most common reason why people get perforated eardrums from a pathology is acute otitis media, right? So when you have acute otitis media, the fluid builds up, pressurizes, there's no outlet, it punctures through. So they auto-grommet themselves, basically, comes out, okay? And then they're left with a little small perforation, which usually heals over time. the reason why this is actually in the ear trauma slide is why?
White.
Potentially flight, yeah. Anything else?
Diving.
Diving, yeah.
Could be
What's
a
more common
slap,
than that?
A slap
Yeah.
to the face.
Yeah, by far. So,
What did you say? What did you say?
cotton buds.
Cotton buds.
Cotton buds, right? Absolute bane of my life, these cotton buds, okay? Now, I kid you not, right? I've seen patients clear out their entire eardrum and ossicles with the cotton bud. Right? So they've gone so deep that it punctures the eardrum and they've just ripped out all the ossicles and then they're stuffed.
Literally
stuffed.
Literally
I mean, we can do things to rebuild it with titanium prosthesis, but the most common reason for a traumatic injury to the tympanic membrane is cotton buds, right?
But presumably, if they continue, they could do that to your tympanoplasty too, right?
Yes. So
They need to stop themselves.
correct. So I actually tell them, please throw away every single cotton bud in your house. Please stop using it. I say, please read the warning labels behind. So cotton buds, most common reason.
It's so funny because the most common reason for you people to use cotton buds is to clean the inside of their ear. But the only warning on the product is do not use inside the ear. It's like we learned this from children that we should use and clean our ear, but it's the only thing it warns us not to do. It's so ironic.
Yeah. Yes.
What else is it for? I don't know. Other things. Definitely other things.
Sorry?
Applying steroid gel to ulcers. That's another one.
Oh yeah, so we're getting to other causes as well. So other causes potentially are not cancer, but there is a ear pathology known as a cholesteatoma. Anybody know what that is? Yeah? Good. So it's basically squame cells that have accumulated in the middle ear where it shouldn't be. So then it turns in, is a destructive process. So it's not a true neoplastic pathology, but it behaves like one. So sometimes, yes, you can have perforated eardrums because the cholesteatoma has eroded through the actual eardrum itself. But you will be able to tell. The reason being is because the cholesteatoma just looks odd. It looks out of place. It shouldn't be there. If you see, like, we frequently describe it as a pearl-like structure, right? It has a pearl-like appearance. Literally looks like little pearls that have basically started growing. Sorry? Bunch of grapes, yeah. Bunch of white grapes, basically. And it's white. Cheesy is another description.
How many week referral to see this?
I would say semi-urgent. I think within 6 weeks.
Is cholesteatoma it's not on the 2-week wait?
No, it's not. Because it's not cancer.
You would send it to the urgent clinic.
Yes. Yeah, if you're worried about cholesteatoma, send it to an urgent care clinic. Okay?
Does that membrane have any tympanosclerosis or is that just ossiculation?
Yes, possible. Yes, just here.
So I've seen a very
That's
few
tympanosclerosis.
tympanosclerosis in urgent care patients. Would I ever worry about them if they're not?
No. So tympanosclerosis, for those that are not aware, it's basically a scarring of the tympanic membrane. So what's happened is that because of chronic infection or traumatic injury, the eardrum becomes inflamed and scarred. And when it scars, it has this white appearance, this patchy white appearance. You see this frequently in children or adults who have had recurrent ear infections in the past, or just generally in elderly people because they've had more time to be infected. Please.
Can topical steroid-based drops cause this?
No.
Question was, can topical steroid-based drops cause this?
Excessive topical steroid-based drops, what it may cause is meningitis. So it causes inflammation, excessive inflammation, strangely enough, as a sort of refractory rebound effect. It may cause increasing prevalence of fungal ear infections. We can talk about that more in a second. But tympanosclerosis, mainly it's scarring from inflammation.
And the risk of this when it gets infected, say if water gets in, is an otitis media.
Yes.
Yeah, I mean, you just treat in the same way with an open perforated membrane you treat with amoxicillin and that sort of thing.
Yes. You can also, if you want, with a perforated eardrum, give eardrops that are not ototoxic. So things like Silodex are fine, but no gentamicin-based eardrops because it will penetrate, it will go through and treat it. But yes, oral antibiotics that we talked about. So ciprofloxacin is a good option. Silodex is a good option. Yeah, it's ciprofloxacin and dexamethasone combination. Yes, yeah.
If it is perforated and it depends on the size
the bigger it is, the lesser chances of healing. So if someone comes with traumatic perforation, would I manage in primary care, or would I refer to ENT?
A very good question.
Manage, review 6 weeks, and then refer.
Very good question. So
you repeat
the
that?
answer, yeah. So when would you refer a traumatic injury, a traumatic perforation of the eardrum? You would refer depending on the mechanism of injury. So if they come to you and say, yep, I've used my cotton buds, I've punctured it, less urgent. If they come to you and say, look, I've been involved with an assault, yeah, and now my eardrum is perforated, someone stabbed me with something in my ear, then you need to refer more urgently, not necessarily because of the perforation per se, but to make sure that the other traumatic sites of injury are looked after by ENT. Yeah, because you can have other areas of temporal bone fractures, the actual, eardrum itself, the sort of ear canal. So because of the mechanism of injury, you're referring. But if they come to you and say, look, I think I've just overused my cotton pads, it's fine.
Can I slap?
Sorry?
Would that be a same day referral, just due to...
Yes. Yeah.
Okay, what was I going to say? Yeah, what about a slap? Can a slap or across the face lead to a
Yes.
Yeah.
Yes, and again, if a slap across the face is so powerful that it's perforated the eardrum, what other sites has it damaged? So you need to, you need to be a really big slap back.
I think that's on YouTube.
Yeah? Good. Excellent. All right, so we're moving on to the nose now.